G'day everyone, my name's Craig Harrison, and in this presentation we'll be discussing type 2 diabetes. We have already learnt that there are currently 422 million people in the world living with diabetes, and this represents about 9% of all adults. Interestingly, diabetes is undiagnosed in as many as 46% of these individuals, and we'll discuss some of the reasons for this later in the video. It's estimated that an additional 200 million people around the world will develop diabetes by 2035. And if this trend continues, it is likely that 1 in every 3 adults in Western countries will be diabetic by 2050. The exponential growth in the prevalence of this disease is primarily due to the increase in adult onset or type 2 diabetes. So what are the causes of type 2 diabetes? At the heart of this condition is insulin resistance. Muscle, liver and fat cells do not properly respond to insulin and thus cannot easily absorb glucose from the bloodstream. We saw in an earlier video that insulin binding to its receptor triggers an intracellular signaling cascade that leads to the translocation of GLUT4 to the membrane and the subsequent uptake of glucose. In insulin resistance, this signaling pathway is compromised, most likely by ectopic lipid accumulation or the activation of inflammatory pathways within muscle and liver. Regardless of the trigger, the consequence is always the same. Less GLUT4 translocates to the membrane, so less glucose is taken up by the cell. Initially, the body copes with insulin resistance by increasing insulin production. This process is termed beta cell compensation. And for a time, the extra insulin is able to maintain relatively normal GLUT4 translocation and glucose uptake by cells. It's important to recognise that insulin resistance and beta cell compensation are occurring in parallel. As our cells become more resistant to the actions of insulin, the pancreas must produce more of this hormone. Of course, the continued increase in insulin production cannot be sustained, and eventually the demand on the beta cells leads to dysfunction. At this point, the beta cells are exhausted and insulin production actually declines. This, coupled with continued insulin resistance, leads to a further reduction in glucose uptake, an increase in blood glucose levels, and hyperglycemia. The relationships we have just discussed in the previous slides are well summarised in this graph. You can see that as insulin resistance progresses, represented by the orange line, the body responds by increasing insulin production, the green line. While these two processes are balanced, glycemic control is maintained, as you can see in the pink and blue lines. However, at some point in the progression of type 2 diabetes, insulin production reaches a maximum. Although this maximal production of insulin can be maintained for some time, and this time can vary between individuals, at some point the beta cells begin to fail. Insulin production decreases despite insulin resistance continuing to rise, and glycemic control is lost. Interestingly, type 2 diabetes can remain undiagnosed for a number of years because the hyperglycemia may develop gradually without obvious symptoms. Despite this mild presentation, patients during this period can develop the microvascular and macrovascular complications of diabetes, which we'll discuss further in the next presentation. There is a strong genetic predisposition for developing type 2 diabetes. Many people with this condition have a family member that also has type 2 diabetes. And over the past 15 years, genome-wide association studies have identified more than 100 genes that contribute to the risk of type 2 diabetes. For those of you interested in the genetics of this condition, those genes are listed on this diagram. However, as many of you would be aware, environmental risk factors are the major contributors to the development of type 2 diabetes. For those individuals with a genetic predisposition to developing type 2 diabetes, their risk is greatly increased by a number of modifiable lifestyle factors, including overweight and obesity, high blood pressure, insufficient physical activity, and poor diet. Over the next few slides, we'll look at the contribution of obesity to insulin resistance and type 2 diabetes. You can see in this first graph for both normal and obese individuals without diabetes that changes in blood glucose levels following a meal are fairly similar. However, the next graph shows the corresponding increase in insulin levels, and you can see that they are significantly higher in obese individuals. These results imply that higher concentrations of insulin are required to maintain normal blood glucose levels in obese individuals. That is, obese individuals are typically insulin resistant. So DeFronzo and colleagues have suggested that 3 distinct mechanisms link obesity to insulin resistance and a predisposition to type 2 diabetes. Firstly, increased production of insulin resistance provoking cytokines such as interleukin-6 and TNF-alpha by the expanded visceral fat depots and immune cells. Secondly, ectopic fat deposition, particularly in the liver, but also skeletal muscle, which impairs insulin signaling and activates additional inflammatory pathways. And finally, mitochondrial dysfunction and endoplasmic reticulum stress within muscle and liver cells, which further exacerbate insulin resistance. In many, but not all obese individuals, insulin resistance progresses to diabetes. If we consider the age-adjusted relative risk of developing type 2 diabetes at different BMIs, you'll note for both men and women that the relative risk increases dramatically for those with a BMI above the healthy range, that is above 25, and this increased risk is particularly evident for women. While insulin resistance is the earliest detectable abnormality in individuals who are likely to develop type 2 diabetes, overt diabetes does not occur until beta cells are unable to secrete sufficient amounts of insulin to offset insulin resistance. Multiple factors contribute to beta cell failure. Insulin resistance develops in peripheral tissues. This leads to the pancreas producing more insulin to overcome the resistance of the peripheral cells. Eventually, this results in beta cell failure and a reduction in insulin production. The reduction in insulin production, of course, leads to a further decrease in glucose uptake by muscle, liver, and fat cells. Collectively, this results in hyperglycemia. Hyperglycemia drives increased glucose production and release from the liver, which exacerbates the situation. With the reduction in glucose utilization, the cells switch to using fatty acids as their fuel source. The fatty acids are derived from lipolysis in white adipose tissue. This means there is now increased lipid and glucose circulating around the body. These have lipotoxic and glucotoxic effects on the pancreas, further exacerbating beta cell dysfunction. Other factors, such as changing microbiota or a decrease in GLP-1 production from the gut, or inflammatory factors, can also contribute to beta cell failure. In addition, because of the hyperglycemia, there is an increase in glucose absorption from the gut and an increase in glucose reabsorption from the kidney, again contributing to blood glucose level increases. All of these processes combined contribute to beta cell failure and the pathogenesis of type 2 diabetes. In the next video, we'll have a closer look at the short and long-term complications of diabetes and the various treatment options that are currently available. I'll see you then.